Okay, so we're going to spend about 15 minutes talking about INH rifapentine as the recommendation 12-dose treatment for latent TB infection. So I have control of the slides, right? I do not, nor does my spouse, have any financial or other relationships with any commercial interests within the past 12 months. And the objectives are as follows here. You can read these on your own. But essentially, we're going to talk about 3-HP and all the ins and outs of using this as one of our therapies. So the real issue here in treating LTBI is getting to a shorter course of therapy that's still effective. And so this is our shortest regimen, which is essentially 12 doses, both INH and rifapentine once a week for 12 weeks. And the regimen here is found to have higher rates of treatment completion. This is the main issue here for these short course therapies, and lower rates of side effects. We'll talk about that in a little bit, but it's variable, the response people have, and studies that show the side effects. I mean, logically, it makes sense that INH has side effects, rifapentine has side effects, and that it's got to be a combination of both. And I'll talk a bit about the initial study that looked at the rate of side effects, but some studies are showing us that it's actually lower than either INH or rifapentine alone. I put up a word of caution about that because my own personal experience is different than that, and I think some of the studies show us the side effect profile, and I'll go through that data for you. What has been a change, and we'll talk about these updated CDC recommendations that came out in June, is that this can now be self-administered. While when this first came out, it was really only with directly observed therapy. The newer recommendations since June have allowed for self-administered doses without DOT. And we'll go through some of that data. So the premier study for looking at this was a TB Trials Consortium study, number 26. This was multi-center study, which included US as well as non-North American sites such as Brazil and Spain. Of course, Canada looks like us. Large numbers. I always look for what's the number of patients involved, and 8,000 is a good number, which were classified as high risk, of which was either 72% of these were contacts of TB cases, so known infectious case contacts, and 24% of these were recent converters using the skin test. What the study essentially found, I'm boiling this study down to some pretty simple principles here, which was of this arm, one arm was INH for 9 months, which is our standard recommendation. The other arm was 3 months of INH and rifapentine, that they had similar efficacy in preventing TB. And there were 15 cases found in the INH arm, and there were 7 cases found in the 3-HP arm. They were pretty close to the same. But that recommendation or that finding of saying, hey, similar efficacy with this 12-dose regimen was great news. And probably more important is the completion rate within that study was much higher with the 12-dose regimen versus the 9-month. Well, no kidding. We're not surprised by that. That is something we would expect. And what we found, though, in the toxicity in this study is it was slightly higher in the INH rifapentine. Statistically, it's 5% versus 3% in the 9 months of INH. But what they're pointing out is that this excess toxicity was hypersensitivity. So we'll talk, I'm going to go through the medication effects from both these medications, INH and rifapentine. But what we're talking about here with hypersensitivity is probably my single biggest concern about this regimen, which is this flu-like symptom, hypersensitivity to the medication combo that's found in a fair amount of people. And I'll show you the numbers, but it's around 4% that this higher toxicity in this study, the 5% versus 3%, was really thought to be more to this hypersensitivity that we'll talk about. So CDC updated the recommendations after looking at a couple of other studies and a meta-analysis, came out with these recommendations in June, and the big changes here is that INH and rifapentine are not recommended for kids under 2. Previously, it was 11 and older was who it was recommended for. So now what we're saying is we can use this therapy for anyone 2 years and 1 day old and older. Okay, but it's not everybody. There's a couple exclusions. You can now, there's enough evidence that we can use this in HIV infection, so people with HIV infection, including acquired immune deficiency syndrome. And a reminder that there's currently no data for use of 3-HP in HIV-infected children at this time. Certainly, infectious disease experts are using it in kids, but there's no good data to guide my recommendations to you about using this in HIV-infected children. So I am at 2 years and older, and case by case on 2 and older who are HIV infected. Reminder that INH, not INH and rifapentine, is a preferred regimen for pregnant women. And this is, I put this in here to remind me, we came out with some LTBI guidance for Washington State this summer. I just want to make sure that everybody has a copy of those. That is pretty clear in our guidance that INH is the preferred regimen for pregnant women, but this may change over time. Who out there needs a copy of the Washington TB LTBI guidance? Because we can send that to you after this meeting. Raise your hand if you need it. Heidi, did you want to say something?
Yeah, there's a link to both the full guidelines and the one-pager in our agenda today.
Oh, great. Thank you very much for doing that. Okay, and so here's the dosing. The standard dosing, which all of us as humans are not all the same size, as you can imagine.
But paperwork for Brianna Martinez, that was the South Richland, right?
Okay, whoever's talking, mute your phone because you're coming across. For those 50 kilograms or more, the standard regimen is INH 900 and rifapentine 900. So is everybody clear how that differs from just like a rifampin alone? The rifapentine dose looks a little bit different. It's higher, obviously. It's a different medication, and rifapentine has a much longer half-life. So that's why the numbers look a little strange, but it is 900, 900. The logistics of that is it's 3 INH tablets and 6 rifapentine tablets, which is a little bit clumsy. And for kids, just a reminder, we don't recommend making the syrup for INH. You got to crush the pills because kids can't tolerate the syrup very well. So even in kids, as you do your dosing, which is as follows, I'd recommend you crush the INH pill. And here's the INH dosing for you based on your weight. Again, this is a weight-based dosing. Us as pediatricians are pretty comfortable using the 50 milligrams per kilogram, and we round it to get it to a pill size, and we crush them for INH. But for other weights, here it is spelled out how you can do this by weight. Again, this table is also put into our guidance, our LTBI guidance, that the link is listed on this announcement. And the same goes for rifapentine. Here's the thing about rifapentine. There's no standard milligram per kilogram dose that's easily available. It's really just given in this dosage. 10 to 14 kilograms is a 300 pill, and as you can see. So this is really more for reference. And again, you don't need to use a slide set for reference. You can use the LTBI guidance. Again, once weekly. All right. This is part of our LTBI guidance I just want to remind us about, and that is the evaluation that really should be done before initiation of LTBI treatment. And I think this was best informed for me when we had a lot of hepatotoxicity from INH, and I invited the CDC into Washington State to investigate, and they were very clear with us what the standard of care for LTBI treatment was. One, that the person should be seeing a medical provider, either an ARNP, a nurse practitioner, PA, or physician. and that these elements of their evaluation were documented, not just done, but actually documented in the chart, that we went over their history, obviously age, weight being one of the most indicators of is someone improving on therapy or are they losing weight due to activation of TB. What other meds they're involved with, because again, INH and rifapentine have a lot of med-to-med interactions, and I'll talk about those in a minute. Is the person breastfeeding? Are they pregnant? And do they have underlying liver disease? All that should be documented in the chart. And then a chest x-ray, and this comes up, and I know, Greg, you brought this up last week, about for most people we do a one-view chest x-ray, but in kids less than 5, the recommendations or guidance around this is really kids under 5 should have both a PA and a lateral chest x-ray, so a 2-view to recognize adenopathy in the hilum is the main issue. And then baseline and monthly liver function tests, as listed here, should be obtained for the following people. And I'll be honest with you, I pretty much do LFTs in anyone that I start on therapy. But these are the CDC recommendations, and they're certainly in our guidance. I don't think you would be faulted if you are checking these in people just before you start them on therapy. And the CDC also points out to us that we have to document that we've educated the patients about those potential adverse events. You can't just write, I talked to them about it. You actually have to document that you talked about potential adverse effects. And then advise that we stop 3-HP if any adverse effects develop. That gets a little tricky when we have this hypersensitivity reaction going on. And then lab evaluation if you stop therapy or if they're having symptoms. Very clear these things have to be documented in the chart. So to take a minute to talk about INH or rifapentine adverse event, 4% of all the patients that we're putting on this regimen experience flu-like symptoms with fever, headache, dizziness, nausea, muscle and bone pain, rash, itching, red eyes, or what is being classified as a systemic drug reaction. So 4% is a fairly significant number. I'll be honest, the last 10 people that I put on this regimen, over half of them have had this reaction that after about 3 doses, a couple hours after they take their meds, they're having massive flu-like symptoms. This is achiness and nausea. And, you know, they may do it 1 dose and just think, well, I'm not sure what that was. But the next time, the next week, a couple hours after they take this dose, they're having these serious side effects that they're linking directly to, wow, it's just hours after I take my meds, INH and rifapentine. So I don't have a good answer for this yet. I'm just making people aware of this as a known systemic drug reaction. It is being seen, and I'm not sure what all your experience has been with it, but clearly is a real thing in 4% of patients. Okay, INH, the main issue with INH is hepatotoxicity, I guess. Hepatotoxicity in about 10 to 20%. That's a wide range. So anywhere from 10 to 20%, whatever study you're looking in. And this issue of peripheral neuropathy. Rifapentine tends to have much less hepatotoxicity, so 0.6%, which is one of the reasons I really like rifamycins is because of the low hepatotoxicity. Not that it doesn't happen, which is the reason I'm pointing out. 0.6% is still some folks that get hepatotoxicity. Itchy rash or just itchy skin, lots of GI symptoms, nausea, vomiting, and even diarrhea. And then some of these more rare things like nephritis, thrombocytopenia, and hypersensitivity reaction are rare with rifapentine by itself. And again, the big issue being orange discoloration of secretion. So a reminder, anyone that has anything that's touched by a body fluid, and use your imagination, will stain orange. So contact lenses, if you're not advising your patient about, hey, look, your contact lenses, tears are going to be orange. It tends to get lesser over time, but you can certainly ruin a pair of contact lenses because they will stain orange. The most common med interactions that we talk about, certainly with rifamycins as most, are the list that follows here. The antiretrovirals, so warfarin and methadone are the big issues here, and it does cross with some opiates, but the big issue about antiretrovirals changes, it's lessened with rifapentine or some of the other rifamycins, but the current guidelines are updated like every quarter. So I put the link here. This is the best guidelines I always go to when someone comes in. They're on an antiretroviral that either I forget if it's got an interaction or it's a new one I haven't seen before. And I always check here to make sure. I personally use Epocrates as a med interaction check. I don't know if any of you guys have that on your phone, but that's what I use, which also reference and keeps up to date with this guidelines that I'm putting right here. So that is it. I guess one thing I wanted to talk about is what our experience has been with this significant hypersensitivity reaction with INH and rifapentine.